Welcome, I'm Brent Hunsaker from CBS2 in Boise, Idaho. I've been asked to host this webinar from One More Day. It's dedicated to suicide prevention among those who are currently serving and have served in our military. Together, we want to explore the key, with the key leaders in the field of suicide prevention, how to develop these community-based prevention and resiliency models. Attendees, you folks out there, will hear the best evidence-based practices that are being deployed both in the military and also in the civilian sector. It's our hope that attendees will be able to determine ways forward for their sectors and their commands to implement effective models that will ultimately reduce the rate of suicide. By the end of this webinar, we hope that you have gathered insights and discovered new resources. It's important for you to understand that it's necessary to collaborate with the various constituencies to break down the silos associated with suicide prevention. We want to find ways to work together to focus all of our efforts on stopping this ongoing tragedy. We believe that there is a tremendous opportunity to do that. That's why we're here today. Now, I'm here with David Conley. He is the founder and executive director of One More Day. We have board members who are watching. Just to introduce you to this organization, let me quickly go down and introduce you to the board members. There were 6 in all. Greg Bryn has extensive fundraising background, over 20 years of experience at institutions like Yale University and Valley Forge Military Academy and College. There is also Major General retired Walt Lord. He's a military advisor right now in residence at Austin Peay State University in Tennessee. General Lord introduced, or was enlisted rather, in the military in 1982 at the age of 17. And he concluded a 36-year military career in July of 2018 after serving as military executive director of the Reserve Forces Policy Board in the Office of the Secretary of Defense at the Pentagon. Now, one more that I need to mention here that won't be a presenter today, that's Brigadier General retired Ed Brandt. He's a Presbyterian minister. General Brandt was the Deputy Chief Chaplain with the National Guard and served in Operation Iraqi Freedom. Those are some of the board members. The rest of the board members will be presenting today, and I'll introduce them as we get to their speeches. In fact, let's go ahead and start with our first presenter. That is Dr. David Rudd. He is President and Distinguished Professor of Psychology at the University of Memphis. He has published extensively on suicide assessment, critical treatment, and management, in addition to conducting a number of successful randomized clinical trials. A veteran who has served during the Gulf War, he founded the National Center for Veteran Studies at the University of Utah. And Dr. Rudd, we invite you to begin your presentation now.
Yeah, absolutely. Thank you. I appreciate the opportunity to speak with you for a few minutes. So I'm just going to talk about 10 minutes about interventions and what we know that makes a difference clinically. Some of the evidence that we have been able to accumulate over a number of years in terms of randomized clinical trials with active duty military and with veterans. So if you look at the work that's been done over the last number of decades, what we've discovered is that there really are commonalities of things that work. There's just a handful of things that are helpful in this area. One is we really need to approach this with a very simple model that patients can understand, that people can understand. We need to do it with fidelity. So we need to make sure that people deliver treatment and clinical interventions with fidelity. We need to make sure people can comply with those clinical interventions and are able to adhere to the protocol. And if they can't, we need to make sure we understand why and help them overcome those barriers. Now, what seems to be most effective in this area are interventions that focus on developing some very basic skills and look at basic skills training as a significant part of what we do. And as an example of that, it really is the capacity to engage in what we call emotion regulation, the ability to manage emotional upset more effectively, coupled with improvement in ease of access to emergency services when needed. So I'm going to mention a couple of things here in just a minute about what's called crisis response planning, or safety planning. Many people have heard that language, and what's called means safety counseling. The idea of removing access to lethal means. It's a really simple intervention. It's one that works and one that saves lives. I would tell everyone that the most simple thing you can do that will save lives is for somebody that owns firearms, simply give them a trigger lock. Ideally, during periods of significant stress and upset, we would remove access, but ultimately simply limiting access makes a big difference. Now, I would encourage people to take a look at the work that we've done, and we've called the treatment brief cognitive behavioral therapy for suicide prevention. It's a treatment that focuses very specifically on building skills around self-management in emotion regulation. It uses safety planning, teaches people how to ask for help. One of the most significant things that I think is it goes unrecognized is the reality that people that have difficulty oftentimes struggle with shame and stigma and have difficulty simply asking for help at these critical moments. And teaching that capacity is really important. The treatment that we developed is only 12 hours long. And as a part of that treatment, we do the skills training. Now, we ended up able to reduce overall post-treatment suicide attempt rates by 60%. As a part of that, we also did very simple safety planning with people in emergency departments. So if you go into a hospital emergency room that we're thinking about suicide, we had an intervention where we simply did safety planning coupled with means safety efforts in terms of restricting access to lethal means. That reduced post-treatment suicide attempt rates by 76%, which was really remarkable. When we dug into these numbers and tried to understand what was happening a little better in a little more detail, what we really discovered is that these very simple things help improve somebody's wish to live. That ultimately what it does is it generates hope. It reduces the wish to die and moves people in the direction of survival. So let me just describe a couple of things really quickly. And one of those is what's kind of called a crisis response plan or a safety plan. A crisis response plan is really just a memory aid that facilitates steps that somebody needs to take in the midst of an emotional crisis. It really is just a checklist, a personal checklist for somebody when they're in an emotional crisis. It's a problem-solving tool, and it's a collaborative strategy that they develop that when they are stressed and they get in a crisis, how do they respond? And as a part of that, we always do means safety counseling is a critical piece, and I would encourage everyone to take that step as a part of the process. And that means you ask every individual that you interact with, every patient, about access to lethal means, and specifically about firearms. They develop a written plan for how to restrict access, whether that involves a family member or a friend. And it really allows somebody to reinforce the steps that need to be taken to be safe while they learn better emotion regulation skills. There are a number of studies that have been done in this area that have demonstrated when you take a simple step like that, and just simply addressing the issue, it's been discovered that you can increase safety steps by almost 2.5-fold in terms of what you see if you don't take that simple step of having that critical conversation. One of the other things that we've done, another simple step, is what we call a survival kit or a hope kit. And for many of these things, you can now do them on your phone. And in a survival kit, again, it's just a simple stepwise process of things that people can do to enhance a feeling of hope and help regulate emotion and help deal with upsetting feelings more effectively. We simply ask people to put together things that help them feel hopeful or encouraged during times when they're overwhelmed. Oftentimes, those are images, pictures of loved ones, letters from loved ones that they put together, make them accessible and available. And again, you can do all of this on your phone now. There actually is a Hope Kit software package that you can download and do. And what's what really has proven critical about each one of these steps in terms of crisis response planning, survival kit, and means safety counseling is it buys people really a critical few minutes of time during these periods of significant risk. And oftentimes those few minutes is enough to slow down the sequence to help save lives. We've got really nice scientific evidence of this now. And we've demonstrated, I think, very effectively with brief cognitive behavioral therapy that brief treatments can be remarkably effective with long-term impact over several years after treatment. And that these really simple steps can save lives. And I would encourage people to consider it, look at the data, be happy to send people information about what we've done and how we've done it. And then the last thing I would share is we have now created a digital app. So we've got a digital app that you can do the interventions and the treatment on your phone. And it's an app that can actually drive better fidelity for clinicians that are trying to deliver the care. So that they can deliver the care more effectively using the app in concert with the individual, with the patient as they move through. And certainly the app increases access to two things. One, to empirically validated care, but also emergency services in terms of safety planning, means safety counseling, and the idea of a survival kit or a hope kit. So I'd be happy, I'm gonna stop there, David. I want to make sure that we've got time for David and Rick to talk and then answer questions, but I'd be happy to share more detailed information. Just send me a note, send you a copy of the studies that we've done, the work that we've done, and some references to some of the protocols that are easy to deliver and made dramatically easier by the digital therapeutic that we've currently developed. So with that, David, I'll turn it back to you.
Before we move on, we are going to do Q&A. So if you've got questions along the way as you hear these presentations, jot down your questions and we'll open it up at the end after the three presentations for those questions. Next up, we have David Connolly, who, as I said, was the founder and also the executive director of One More Day. The nonprofit's goal, very simply put, is to assist military veterans, first responders in reducing suicide through training and identification of resources. It's a very focused goal, and David, take it away.
Thank you, Brent. I want to welcome everybody. Thank you for coming again. This one's a little different. At the end of the last couple webinars we've done, I've received emails, multiple emails actually, from a lot of the generals and people on the call saying, it's great you're doing this, but we need something that we can apply today. What can we do to reduce suicide today? So that's the primary reason that I asked Dr. Rudd to be on here. The app is awesome that we can get some of the soldiers around the stigma of asking for help. We're trying to work right now at getting some numbers as far as how many people have actually had suicidal ideations that they've reported versus how many are still in service. I think that's going to be a huge number. But in an effort to answer the challenge that I was given, we've created and are launching in the process of launching two programs right now. First is Operation Better Together. That program, what we're doing, one of the big weaknesses that I've seen since I started in suicide prevention is there's not a lot of interaction between our military, whether it be active duty, guard, even veterans, and the local police organizations that surround them. Now, while that may not seem like a big deal, the vast majority of our suicides in the military do not happen on bases. They happen in the civilian world. So it's imperative we get as many of these officers trained, not only trained, but establish those relationships. So that way the commands, we start knowing when our people are having problems, as opposed to them just being taken to an emergency room, put on a hold, released, and you never found out about it. So what we're doing is we're going to create a series of ASSIST, which is, for those who don't know, that's Applied Suicide Intervention Skills Training. It's a 2-day program. It's incredible. Most of the military already uses it. Rick Trent, who's one of our board members and also the president of Living Works, will be talking a little bit about how these programs are going to interact with what One More Day is doing after. But we're going to set up these different workshops all over the country. And in these workshops, we're going to have half of it, approximately anyway, we'll have half of it being police officers, half of it being our gatekeepers or suicide prevention people. One of the things that we found out when we did our first set of training back in November, where we combined the two, is if we allow it, when we have police and military, they're going to go police on the right side, military on the left side, there'll be no relationship. We lose half of the benefit of this program. So what we're looking to do is actually have the instructors assign seating pretty much. We're going to partner up a police officer with a gatekeeper, police officer with one of your suicide prevention people. That way they've got to go through all the role playing together. It really establishes that relationship. When we started doing that in our other trainings, the results were just hugely better. So that's the first thing. We will be submitting it also to the NGB incubator to become a program with the National Guard. We're working with some of the generals in the Air Force and the Army right now as getting those adopted programs as well. So that's our first program. I think that one we're going to be rolling out in probably Wyoming and possibly, hopefully a couple other states as well within this year. The second program we have, and this one is really in its infancy stages, is called Operation Reaching the Future. One of the things that I've heard from every leader so far is I cannot get our people around the stigma of asking for help. So how do we do that? Well, that's why we brought Dr. Rudd and his program in. We're starting to identify different resources for that. But I think a big part of that is going to be getting to them and training them that you're not weak because you ask at even a younger age before they become service members and before they become veterans. So we're going to do a series of mentor-based webinars for them. So we may be working with one of the services or the different associations to bring in an astronaut or a former astronaut, a fighter pilot. It could be a doctor, rocket scientist, pretty much anybody. What we want to do is create that bond with the kids. Hey, here's your hero. And then from there, we're going to hopefully have these mentors saying, hey, even I had to reach out for help at one point. This program is a little bit earlier on, so a lot of the details are still to be developed. But our response to both of them, we've got the different state suicide prevention groups that are involved in these now. We've got multiple Guard units. We've got quite a few with active duty. I met with the Air Force Pentagon the other day about this. So we are making progress. But I really want to get at least Operation Better Together off the ground as quickly as we can. I think that's going to be a huge thing. A lot of our departments are hopeful of having 20% of their officers trained in what's called CIT, which is crisis intervention. And if we can do this right, I think we can add another 20% of that in assist. And that's the goal. The more officers we have properly trained to deal with suicide, it's simple math. The more of our people that are going to survive this horror that we're dealing with right now. And that's it for my two programs.
Okay, David, thank you. Our final presenter is Rick Trent. He is president of Living Works, which developed ASSIST, which David was just mentioning, Applied Suicide Intervention Skills Training. Mr. Trent is a Navy veteran and has spent the majority of his career in healthcare as both a provider and an executive. Building on his depth of experience in public health, Living Works takes a community development approach to the issue of suicide prevention. Living Works proudly works with all branches of our military community, training members who are serving and those who have served. Mr. Trent. We'll have to start off.
Don't worry about that. That happens all the time.
That's a promotion for you, Rick.
It's just one vowel off. So thank you everybody for joining us today, and it's absolutely my pleasure to be able to present. It's our hope that you'll see the synergies between what Dr. Rudd has presented, what I will be presenting, and what Mr. Conley has presented as far as new initiatives. Initially we had talked about the importance of community, and that's really where Living Works is focused. The community development aspect is much akin to the analogy that it takes a community to raise a child. It also takes a community to address this issue. It takes a community of people to keep people safe who are struggling with the issue of suicide. And it takes a community of people with different roles and different skill sets in order to come together and to surround that individual. The Living Works approach really is about that community engagement and developing skills in community. And it also takes leadership to be able to lead within a certain community, whether that be a workplace or whether that be out in the communities where we live, work, and play. Living Works, just quickly, has been around for well over 35 years and solely focused on the issue of suicide, and has been really has built the most solid evidence base of programs in the industry. And that's really important to mention, because I believe that the evidence behind what we do has to be compelling, and the approaches that we use have to be evidence-based. And Dr. Red talked very much, about the importance of evidence in the work that he does with clinicians. Ours is the same, is that it has to be evidence-based training in order to develop skill and to know that we're actually making that sort of community development transition in our communities. So where we train is really where people live, work, play, learn, and pray is what we say. So it's very much based on a population health model. So it's a public health model that's really focused on populations of people. And we believe that it takes that community of people wherever we are. That's where we're going to see the issue of suicide. As we develop our roles within community, the one thing that's really important here to understand is that there is no one program that's actually going to make the difference. It takes a suite of programs. It takes a suite of training. It takes community effort, and it takes community-based resources in order to create safety. So I want to give you a couple of examples of that, where we build what I call a safety net. And so that safety net is a coordination of leadership. It's suicide prevention coordinators. It's our family readiness program leads. It's chaplains, family members. It's those that serve and those that have served. It's our politicians, decision makers. It's our communities, it's our workplaces, it's our face systems, it's health systems, it's crisis lines. And so it's that comprehensiveness of community that really is important to create that confidence and readiness for people to support one another. We believe that this is a culture piece as well, and we've heard comments about stigma. Is that positive and support-oriented culture around suicide prevention is really the sustained effort that we need to make over time. Widespread presence of trained people, make sure everybody who is struggling can be identified, but also can be treated and walk through their journey towards hope. Dr. Rudd spoke about the importance of getting our emergency departments trained. And some of my background is in healthcare. And one of the things I'd ask my chief of staff every morning is how many people presented with suicide and where did they go? And the responses were alarming, that, well, we discharge them and we've lined them up with mental health. But what about that gap between the time that they're discharged and the time that they can see mental health? And so our programs within Living Works, Dr. Rudd spoke about that importance of safety planning. You have to fall into a safety net with your safety plan, with the resources around you to keep you safe as you reestablish your hope. And that's very much an example of a community build. Some of that practice that happens in real life when we start working with organizations to pull together a comprehensiveness of an approach. And so I'll give you an example. The USS Nimitz was dry docked for 15 months. And the skipper on the boat brought his leadership together and said, we have to really watch over our sailors. We don't want to have any suicides at all. What can we do? And so what they did is they actually had their community of people trained. They had over 4 people trained of their sailors, and they ended up after that 15 months with 0 suicides. And and so that's an example for me of really leadership stepping up to the plate and saying, this is a serious issue for me. I really care and I'm concerned. How do we get this addressed? And how do we make sure that we keep our sailors, our soldiers safe? So as we go through and identify organizations and what their needs are, I'm going to come back to the issue of no one program actually serves the entirety of the purpose. It takes a system, and it takes a system of not only suicide prevention training, but it also takes a system where you're integrated with your health systems, with your mental health providers, with key leaders within our communities, to bring them together. And so Living Works is very proud to be able to be a part of One More Day and its efforts in the Better Together campaign. One of the things that Mr. Conley had pulled together just to do a bit of a prototyping of this was he brought together police forces in Idaho, and also brought together the National Guard, and they trained together. And so that was a bit of a pilot, to see, does this make a difference? And the conversations that were held throughout the training and even after the training was really focused on how do we address this issue in our community? How do we work together better? And there's already significant momentum that's being built in those communities, just because of bringing these groups together and developing them with a skill set now that they have to work together. So as I know that we're short on time here, and I want to just be fairly quick and fairly brief here, is that the importance of developing our communities of people, the importance of leadership in addressing and owning the issue, and making sure that we're keeping our soldiers, our sailors, our airmen safe, our Marines, whomever in our communities, wherever we work, but also thinking about how do we broaden ourselves beyond those communities where we're training spouses and educating our health systems, bringing together our systems. And there's a number of examples of really good practice that's going on. And so we hope that you're able to take away some nuggets here today to be able to bring those back to your organizations and consider how you'd want to go about this. Living Works offers consultation and planning support and services as well. And I'm not here to give a commercial, but it's just part of our skill set that we can bring into organizations. And One More Day in the capsule that we're forming here is well situated to help any organization that's looking to come up with a solution orientation here for this very issue. So thank you for your time, and we look forward to the question and answer period.
Mr. Trent, thank you very much. Just a side note, we have a relatively new president at the Boise State University. Her name is Trump with an O, so you can imagine that we had some fun with that one on occasion.
All of us with different vowels.
One vowel makes a huge difference, right? Shall we open it up for questions?
Well, one thing I did forget to mention on both of our programs, Dr. Rudd and the University of Memphis will be creating a study or I don't know if you want to call it a study, but they'll be tracking all of our results from the programs. And so we'll be able to report back to not only commands, but to DOD as well on just how effective these programs are. We're hoping to get at least 2 states active this year alone. If we can get more, that's great. We are going to be working through the NGB incubator program as well. So hopefully we'll have some good results by the end of the year for all the commands. And now if you want, we're open for any questions you have.
if I could interject here, I have a question for Dr. Rudd. You mentioned fidelity of care. Could you go into a little more depth on what you're talking about? That I gather it's follow through, but I sense there's more to it than just follow through for healthcare professionals.
Yeah, absolutely. It's really delivering, even though I talked about doing some very simple things, it's about doing those simple things correctly. And so one of the things that we have found, and I think the creation of this digital app will help clinicians do that and help non-clinicians do that in some circumstances, that when you set up a safety plan, or when you do some basic mean safety counseling, or you try to create a hope kit or a survival kit, there really are steps to doing that. And doing those steps correctly is an important part of enhancing hope and having positive impact. And that's where the digital app comes into play. It really helps people do that, do it with great fidelity and accuracy, and as a result, have an enduring effect. And so we're excited about in the coming months, making that digital app more widely available, increasing access, and really helping people take those simple steps and doing them accurately.
And the survival kit or the hope kit that you just mentioned, is this merely concepts of follow through, or is there a physical component to this?
Yeah, there's actually a physical component for that. So it actually is, if you look at a hope kit, it's helping people put together materials that they can actively use, that generate a sense of hope, that help them manage their emotional upset at this critical moment more effectively. There are actually some apps already available publicly that you can download for free called Hope Kit. And you can just go to the App Store, download those. They have very simple instructions. What I think is surprising is how powerful simple interventions are. And one of the questions that I had was for Rick. I did Living Works training 30 years ago, Rick. I don't think you know that, but that's how I got started in this area. I think one of the things that these simple steps do is they help people overcome stigma and shame, and would love to hear Rick's thoughts about. I just think stigma is such a powerful thing, preventing people from doing simple things that save lives.
I absolutely agree with you that it's the simple things. One of the examples that comes to mind for me is during our training, we actually get people to physically state, or ask the question directly, are you thinking about suicide? And you can't believe how hard that is for people because of the stigma of some of the belief systems maybe that they have. But it sounds like a really simple thing, but that's a really difficult barrier to overcome. The issue of suicide has been it's very interesting because it's so heavy with stigma that people see it as a topic they do not want to talk about. And so, if we think about other public health approaches or public health issues that we would have seen over the years, you take HIV, for example, 30 years ago, you couldn't mention it. And because there was a lot of people who were scared about it. But the steady campaign and steady momentum of discussion and getting that discussion in the community has become, it's become a much easier topic to talk about. And I'm not saying it's the same thing with mental health or with suicide, but there's a heavy stigma around it. And so simple training really helps us overcome those barriers and address the issue much more effectively.
One note here, I'm not that well versed in Zoom, but I'm told that there is a method, a way that you can electronically raise your hand if you want to ask a question. In fact, we have one now from Steve Ackerman. Steve, go ahead.
Are you muted, Steve? Steve, can you hear us?
Yes, hello. This is Steve Ackerman. Can you all hear me?
Yep, we got you.
Appreciate it. Thank you, Brett. Thank you, David. We're having a phone change here in our office, and they literally just did it on the landline. So, hence the backup. So I'm a legislative director with Congressman Russ Fulcher, and I had a few questions. First of all, David, it's good to see you again. Good to chat with you. And Brett, thank you for doing this. And I appreciate the panel and the range of conversations that we've heard so far. A couple of questions, if I could, to Dr. Rudd. You spoke about emergency room personnel, the docs and the nurses being prepared to be able to deal with a suicide potential. A person has gone beyond suicide ideation, maybe taken some action. I'm wondering if there's something that we should be watching for from the legislative side when it comes to veterans in particular. I happen to also be a veteran of the Air Force, and I am wondering if there's something there that we ought to look at. There's some things Congress has done recently for emergency room personnel, but that's a more general, but I'm wondering if there's something specific to veterans. And then if I could, to just kind of a couple other questions, because I do see a lot of state legislators on. One of the things that I've heard in connection with sharing the data between DOD and VA is the state veteran services often don't have good data when it comes to veterans coming home and are now going to reside in their state. You know, I've talked with some of those officials over there, and they've told me, they've said, you know, if we could just do a little bit of outreach early on and just chat with the veterans who are now back in Idaho or have moved to Idaho, if there's a way we can know. So I don't know if anybody could talk about some of that data sharing. That would be helpful. And then finally, just anything for Mr. Trent regarding the role of the VSOs and anything that we could do from Congress's side. Is there something there, if anything, just get rid of any barriers to help them be a part of that community? So any order to anybody, but appreciate that.
Yeah, Steve, let me respond to a couple of those points real quick. One, on the emergency department side, the highest risk period, and this is across every risk factor. The highest risk period for death by suicide is within the first week after having been discharged from an emergency room. So it's after somebody has evaluated you in an emergency room, said you don't need to be hospitalized, you can go home. That first week, it is overwhelming in terms of the risk for an individual. And so what I would tell you needs to happen is people need to do two things. They need to have a safety plan, and they need to do means safety counseling of restricting access to their method. That needs to be done with whatever the care provider, the family member that's involved. And if you specific to veterans, it's about limiting access to firearms during these critical periods. So I would tell you whatever they can do to limit access to firearms. And as I mentioned earlier, it can be as simple as convincing a veteran to put a trigger lock on their weapon during this period where they're having difficulty. One of the things we've discovered is veterans do not want to give up firearms, and that's okay, but can they limit access to that firearm during this critical period? So I would encourage you, those simple interventions will save lives. And I'd be happy to share some data with you to demonstrate that, to show you that if we were doing that nationally, it would make a dent in this problem. The last thing I would say about veterans, about sharing data, it's about access to care for veterans who are in isolated rural areas. So it's the veterans that go to these isolated rural areas that don't have access to care is vital. That's why means safety counseling is so important. That's why digital therapeutics is so important. So that's why one of the things we've done in creating this digital app is enhancing access to care for people that are out in these isolated areas and can't get to a clinician. This digital app will give you not only treatment, but give you telehealth access to somebody at critical moments when you need it. So I'd be happy to talk to you in more detail or depth about any of that in the future. Just reach out and let me know.
Appreciate that. I'm certainly hearing about telehealth and the connection to mental health care. And I know some DoD folks have told me that the veterans who are in a lot of smaller towns, and we're the first CD. We have a ton of small towns, and the ability to kind of be able to share more when they're in that private environment, kind of I don't want to say protected, but at least they feel like it's a little more sheltered, and they're from the comfort of their home.
Yeah, and the nice thing about what we know now, Steve, is these problems are not complicated. We just have to have the will to do the things that we know that work. And I think Rick had spoken to this as well. We know what makes a difference, and it's not complicated. We just need to get the will to do it. So Rick, I'll turn it over to you.
Yeah, thank you. And thank you, Mr. Ackerman, for the question. Working with VSOs, it's a very, I think it's a very important voice out in our communities. And I think one of the challenges is that there's so many voices. There's over 30,000 VSOs in the United States alone, right? And so it's very difficult to hear from all of them. But maybe I'll give you a couple of examples of some best practices that I've seen. One of those is in South Carolina, for example. In South Carolina, under the Governor's Challenge, has actually brought in the VSOs to speak to their Veterans Affairs and their committee. And so they're engaging that voice out in community. And as we know, every state has a large number of veterans in its population. Tennessee is doing the same thing, is that it's now really starting to get momentum in its Governor's Challenge and bringing in that voice. And so there's ways to construct that. Another example, to do that is to actually have really purposeful consultation sessions with our veteran community. And because each one of the veteran serving organizations actually has a bit of a different take on it, as far as its purpose. And so at Living Works, I'll speak specifically for Living Works. We work with a lot of VSOs, and we try to engage them, try to create strategy for them, try to engage them to train in their community. And so we do a lot of work with consortiums of VSOs as well. So, for example, Wounded Warrior brings together Team Rubicon, Team Red, White, and Blue, and we have a fairly significant relationship with them. Maybe is a better way to say that. A really good working relationship with them, where we actually sit down and plan. We have planned events every year. We're really encouraged with the work of One More Day because it's doing something in a different way, where it's got a couple of really unique initiatives that we're starting up. And it's serving a community with real practical approaches. And so I don't know if that answers your question, but I just thought I'd give you a bit of a flavor on kind of what my thoughts are.
I appreciate that. I know the authenticity is very helpful here, and clearly you're showing it, and the groups you work with can often bring that. And so I appreciate that, hearing that them is kind of that bridge too for you. Thank you.
Absolutely.
Hey, Dr. Rudd, one question's come up from our Facebook audience. Would the app need immediate response from the clinician concerned with the expectation of availability?
Yeah, actually, the app provides that, David. So the app would, if there is emergency need, the app would connect you immediately to an accessible clinician. It may not be, it would most likely not be somebody that you worked with before, but it would connect you with somebody. So there is that availability as a part of it. Recognizing the nature of this challenge, and I think that's a part of continuity and fidelity with what we know works, is making sure that we have access at these critical moments.
Jessica, you have a question for us?
I do. Good morning, good afternoon, everyone. I'm Jessica Gallus. I'm the Senior Advisor for the Department of Navy suicide prevention program, along with sex assault and sex harassment. So thanks for including us on this conversation. Wanted to ask about safety plans. We've heard a lot about safety plans over the last few years, and I'm wondering if there are certain criteria that have to be met for a safety plan to be effective. Over.
Yeah, Jessica, I'm happy to answer that. Yeah, there are actually. There are a number of things that need to be a part of that that really are critical to inclusion as a part of a safety plan for someone. And so really, let me just give you a couple of critical points. One, there needs to be a threshold for usage. So you need to identify under what context or circumstances somebody uses the safety plan. There need to be a step or two in terms of self-management of their emotional experience. So they need to do some emotion regulation activities. We use what's called a reasons for living card is that first step. And that generates, again, it's consistent with the idea of generating some hope in these critical moments. You can include a step where they reach out for external support with a loved one or somebody that we know is healthy and cares about them. And then the final two steps are always a phone call to an emergency service. That could be the suicide helpline. And then finally, if those things above are not successful, the individual can go to an identified emergency department to be evaluated. So yeah, those critical elements are important. And then in concert with that, every time we implement a safety plan for an individual, we also do means safety counseling. So we would do the safety plan, put it in an accessible form. So it's either on a 3x5 card or you can do it on your phone. So in a form that is accessible and available, and then do the means safety counseling about limiting access to means as well. So yeah, I appreciate you pointing that out. That's a part of the fidelity piece of this, that in order to do safety planning effectively, it has to cover those bases.
If I can chime in as well, one of the that's developed in the ASSIST program is how to develop a safety plan, and it's very much akin to what Dr. Rudd is saying here, with a major emphasis being on that community resource identification and basically drawing a roadmap with the individual at risk. And so as well as what kind of resources do you need to have around you to keep you safe for now, as you access that care that Dr. Rudd has talked about, as you start to walk along your journey and redeveloping hope. That's it's a very standardized process, which leads to that fidelity piece that Dr. Rudd is talking about. Because if it's too loose, unstandardized, then you don't cover those important elements that Dr. Rudd has talked about. And so, back to my example of discharging a person from the emergency department while they're awaiting a mental health service, that's all part of that safety plan, and we have to have people ready to surround the individual to make sure that they're supporting them along their journey. So safety planning is really, really important in this field.
And Jessica, I would add one last point. Absolutely agree with Rick entirely. And the other thing I would add is it really needs to be accessible. When I say that, it needs to be written down. Yes. Part of what happens for people that are acutely suicidal is the level of emotional upset in their symptoms. It disrupts their ability to think clearly during these moments. And so really what a safety plan does is it's a documented, written plan that when you can't think well, when you're distressed and upset, it can clarify the steps that you need to take. It reminds you of the steps that you need to take. And I think I would argue it reminds you of why you might be hopeful in what your reasons for living are. And that really is important at those critical moments. We've been stunned at how effective it is. It is remarkably effective at inhibiting behavior and stopping people from making a suicide attempt.
Thank you so much to both of you. I think those are great points, and just great points on the panel in general around getting folks comfortable asking about suicide and lethal means safety. So thanks so much.
Thank you for your question.
And one quick follow-up on the question that Jessica asked. We talked about getting community leaders involved in this. I assume we're just not talking about politicians, the mayor of a city or city council member. Community leaders are more than that, correct?
Very definitely. We're talking about anybody from a hospital CEO to the different BSOs, counselors, pretty much anybody we can get that can help in this battle is who we need to bring together for this. And that's why one of the things I was going to mention is our target for we're going to be doing this every other month now, doing these webinars. And September's is going to be identifying resources. I noticed one of the comments on from our Facebook Live audience was, we don't know where the resources are. So I don't know if I'm kind of letting my mouth overrun my brain here a little bit, but what I want to do over the next couple of months is work with our board and really any of you that are on the call, let's identify the resources. There are so many resources out there right now who want to help, but the problem is there's a disconnect between them and our troops, them and our veterans. Everybody's working individually in this instead of working as a big group. And so that's what we're going to try to do in these webinars, is just bring a diverse group together and really start dealing with it as a whole instead of individually. So Cara, in answer to your question, that is the whole topic for September, is identifying resources. It's going to be, I think, on a little bit bigger scale than individual states. We're going to be looking for a lot of nationwide resources that any of you can tap into. And, the different areas, we have a ton of PTSD specific. We've got sexual assault, but we don't have any cohesion between them. So that's our goal next, is to start bringing those resources together to make your lives easier. So you're not wasting a lot of your time finding them. We'll do it for you, and then we'll create different committees that are gonna be resource chairs that'll deal with that.
Now, I don't know how much detail you can go into, but you mentioned that you've done a pilot program working with military as well as civilian law enforcement, bringing them together, training them together, getting them to talk to one another. Have you had any success stories from that?
Yeah, we've had a couple actually. One of which is when the verified, because I heard it from the officer involved. We had a young kid who'd been pulled up, just transferred to one of our local bases, and he got pulled over by a trooper. And it was one of those margin calls where the trooper had two choices. One, he could arrest him, or two, he could let him go. Problem was, trooper didn't feel comfortable just letting him go. And so he ended up, the kid, like I said, just reached out, or just been reassigned here. So he didn't have any family, didn't really have any friends. And so he said, I don't have anybody to call. Well, the police officer, who was a trooper that actually had created a bond with one of the guys that are in one of the trainings that we sent him through. So he called his contact at the base sent out a person to pick him up. And the result is we kept that kid out of the civilian legal system. We all know that the first, one of the biggest first steps towards suicide is getting in that legal system. Once you get in there, it is so hard to get out. Now, I'm sure his command had some really unhappy words about having to send a team out to get him, but we kept him out of the legal system. We also had another kid who had tried to commit suicide 3 times. And the officer that was involved in the third time that got called out called his counterpart on the base and told him about it, which that brought it to the first sergeant's attention. And then from what we hear, and again, this one isn't as easy to verify, but from what we understand, he hasn't attempted it since. He's been following all medications, doing his counseling. The service really got proactive at keeping him healthy. So that's, the two things. And we've only put probably, I think, a total of maybe 25 officers through the programs that we've been working with. And that's both assist and safe talk programs that we've done that with. So yeah, we have some results.
So it is working. It can work.
It's working, and it can really work if we have all the cooperation of all the units. It's a huge task to be able to do these workshops all over the country. Fortunately, we do have Living Works. Our president's one of our board members, so as far as collaborating, it's going to be an easier process getting this together. We just need to work really hard to put it together.
We have a question from Mike Holmes. Go ahead and ask your question, Mike. General.
Hi, everybody. Thank you.
General,
Hey,
welcome.
yep. So Mike Holmes, I would say I'm the artist formerly known as General Holmes. I retired from the Air Force last year. I want to thank everybody for the evidence-based tools that you're laying out. My question is, both David and Rick talked a lot about the evidence and the results for getting past one suicide ideation and the stats that we have there. How do the numbers differ when you compare the tools and the intervention tools that we've seen work for getting past one suicide ideation? Is there a difference between those numbers and then how it works over the long term for people?
I think that's going to be more of a Rick and Dr. Rudd question actually for that. Rick, you want to take that?
I'll let Dr. Rudd take that one straight away.
That's a tough one.
Yeah.
Yeah, interestingly enough, Mike, I would tell you that what we find is when you have success with somebody who's made a first suicide attempt, only a small percentage continue to have difficulty where they would consider suicide, make another suicide attempt. Actually, the larger percentage continue to have some enduring effect and success. There is a small percentage of that population that have made multiple suicide attempts, and those, the nature of those clinical problems are a little more challenging and a little bit more enduring. But what we're finding is surprisingly that simple interventions actually endure. We've got follow-up data in our interventions of 2+ years. So it stretches out for quite a while. We're certainly trying to track longer than 2 years, but we've got good data out to 2 years with very simple and time-limited interventions. Mike, I would add that one of the most successful broad-based campaigns ever done was done in the Air Force a couple of decades ago. And the Air Force had remarkable success because of the very things Rick has talked about community and about stigma and about leadership at the highest levels taking a role in reducing stigma. Those campaigns a couple of decades ago were really impressive.
Going back to your question, General Holmes, I absolutely agree with everything that David has said. The addition that I would add to that, and it goes back to the care plan aspect, is that the care plan is not just a one shot in time piece. That accompanies them throughout their journey, and it gets transformed as they're developing their hope, as they're accessing new resources and identifying new resources to help them along their journey. The other piece of this that when a person goes through that initial suicide ideation or has developed a plan, depending on how severe this is, the importance of surrounding that individual with the right resources to keep them safe as they walk that journey. So I always use some health term language, and so I apologize for this, but it's a normal sinus rhythm that we go through in life. That EKG, and when it gets to the extremes, if you've got a really good care plan, it can keep them from going outside those boundaries. And so throughout life, we all go through tougher times, and so we need those supports around us to make sure that we stay within those boundaries. And I think that the care plan, the appropriate systems that can respond to these individuals, helps avoid that second attempt, if you will.
Thank you both.
The thing that struck me about what you guys were just saying is that the first intervention, if you will, for want of a better term, that first time that you have contact with that person and identify the ideation of suicide or perhaps even an attempt, that is the most crucial point in this whole process.
Yes, absolutely. Yeah, and being able to respond to that, yeah, no question about it. And it sets the stage for intervention from that point forward, whether or not somebody is is willing and agreeable to pursuing treatment and care, that first interaction really has significant impact on individuals and about their hesitation or their willingness to pursue assistance.
Well, and it's the perfect story was what you just told me a few minutes ago before we got on air. And that was that there was someone that was contemplating, that was actually taking action to commit suicide, but in the process of doing it, they were going to jump off of a bridge. As they were walking, in their mind, they said, if one person just engages me, if one person just says, how are you, or what's going on, or you don't look right, then I won't do it. But he got to the bridge. Nobody stopped him. There were no engagements. Nobody bothered. There were people all around him. Nobody bothered to do anything. And he went through with the attempt. Failed, but he went through with the attempt.
Well, it's even worse than that, actually. This poor kid was on the bus for almost an hour, and this is Kevin Hines we're talking about, who will be our speaker in July. But he got on the bus, he rode the bus all the way there. He's crying this whole time, and he's just praying. Just one person asks him if he's okay, can I help you, anything? So he gets to the end of the bus, and they drop him off at the bridge. He walks out, he gets about a quarter of the way out, and nobody's talked to him. Nobody said a word. So he thinks, all right, I'll go out to the middle. So he gets out there, and apparently he's got even a foot up on the bridge. And again, crying and so obviously distraught. And a gal comes up to him and says, can you take my picture on the bridge? And he's crying, he's got tears out of his eyes. And that's the lack of compassion. And that's why he launched from there. And the minute he did, he of course regretted it, and thank God he survived. But and that's one of the things that we really push is this isn't a major or overhaul. It's little things that can save a life. Reaching out, calling your buddy. Hey, are you all right? Like that case, the lady you saw him, and he passed two officers as well. Just asking, are you okay? Can I help? It's the simple things that can make such a huge difference. And that's what we're trying to stress through all this is don't overthink it. Just, be there for your buddy. Be there. That's one of the things that we're all ingrained into us is our battle buddies. Just, we got to keep those battle buddies after we get out. So, yeah. And Kevin will be on July 16th. So everybody's invited to that. Doesn't matter rank or anything. We want as many people as we can to hear his story. If you haven't heard him, he's just a phenomenal speaker to listen to. So.
Well, just the little you've been able to tell of that story is incredible.
Yeah, it really is.
We have a question from Gordon Grossclose.
Yeah, Gordon Grossclose.
If I am butchering your name.
Chaplain.
No, it's Grossclose with Armed Services Ministry. David, thank you for making this happen. Question for Dr. Rudd. You briefly mentioned the use of the digital app by non-clinicians. I'm wondering, say, for the use of a chaplain in a military organization or an EMS organization, what might that look like in the application of that app with somebody who may not yet be willing to go to behavioral health? How would that play out?
Yeah, we're actively investigating that now. So we are in the process of looking at whether or not it's a good idea to do the full app independently of clinical care and independently of a clinician. Currently, what we've done is access to the app with limited clinical care when needed. So we're actively studying that and looking at that as an option. Now, there are some apps that you can use that have elements of what we have more extensively. So the Hope Box, that is an app that you can download out of the App Store and use independently. That essentially creates a safety plan to a large degree. And that's available independent of use with a clinician. So there are a few limited things that are available for you. And Gordon, I'd be happy to talk in more detail and depth about it after you take a look at the Hope Box app and see if that meets your needs. And if not, just send me a note and I can talk to you a little bit more about some things you could do without enhanced clinical training to use in non-clinical settings.
Good, thank you.
One thing, Dr. Rudd, I do want to thank you for joining. Dr. Rudd has just become a member of our board, and I think he's going to be an invaluable asset, and I just wanted to thank you for joining us.
Yeah, absolutely. My pleasure. Thank you, David. I appreciate the great work you're doing.
Any other questions? If so, I don't know what the process is. Electronically raise your hand. Any final comments?
I think that's about it. I just hope everybody joins us in July. Like I said, September, we're going to be working on resource identification. So we've got some exciting things coming up, and I look forward to working with you all here in the future.
Yeah, that next webinar is July 16th, right?
Correct.
Same time,
Same time.
1400 hours Eastern, noon here in the Mountain Time Zone. Thank you for joining us today. Again, you know, we're talking about eliminating the silos, breaking down the barriers so that we can help people save lives. It's that simple, and we really appreciate your willingness to be in the breach and to save lives. Thank you again, and we'll see you in July.